Good morning, everyone. Welcome back to my channel, Learn with Dr. Akshita. So, today is the World Aspergillosis Day, that is the 1st Feb 2022. So, this is the fifth World Aspergillosis Day. So, giving visibility to a hidden condition. So, why is this aspergillosis taken? So, this year will mark the fifth World Aspergillosis Day, and the aim of this World Aspergillosis Day is to raise awareness of a fungal infection that is often underdiagnosed. And the diagnosis of aspergillosis is quite complex, and because it frequently occurs alongside with much more common illnesses like asthma, tuberculosis, COPD. So basically, the patient will be treated multiple times for TB, COPD, but without even thinking of aspergillosis. So, let's start with a case. A 30-year-old male, carpenter by occupation, previously treated PTB, completed treatment 10 years back, and treatment was started empirically based on the chest x-ray. Presented to OPD with complaints of altered sensorium from past 1 week and one episode of seizure. Previously, he has also already been hospitalized thrice with history of fever and has been treated with multiple antibiotics, one of which chest x-ray, which is suggestive of lung abscess. He is a known case of type 1 diabetes from age of 10 years. He is also a drug abuser. On examination, patient is pale, thin-built, disoriented and agitated. Neck rigidity is present and Koenig sign is positive. Lumbar puncture was done and CSF revealed protein of 71, glucose 201, WBC 5 to 10, which was again lymphocyte predominant. ADA was 4, so AFB was negative and CBNAT of the CSF was negative. So this picture you can see it's so protein is mildly elevated. Glucose, again, patient had uncontrolled blood sugars, and that could be the reason. Glucose is very high. And NCCT brain was done, which was not suggestive of anything. And viral markers came non-reactive. And he has been treated with acyclovir, ceftriaxone, vancomycin for 7 days with no response. So what are your provisional differentials with this? So whenever you see a very weird looking protein glucose, and you'll always have to think about fungal, because otherwise your usual viral bacterial will have a typical CSF protein and glucose picture. And again, WBC is very limited 5 to 10. So this picture you should always think of fungal meningitis. So fungal meningitis could be a first degree, which could be your query cryptococcal, and it because it was lymphocyte predominant, again your TB meningitis. Also the patient is having history of previously treated pulmonary TB, so TB meningitis also could be your DD. So what are you going to do? Further tests. So CSF cryptococcal antigen test was advised, bacterial and fungal culture, and galactomannan was done. Blood procalcitonin, CRP, and culture were also sent. So with that, we'll start with today's session, that is aspergillosis, diseases, diagnosis and management. So in this part, today's part, I'll be covering the invasive aspergillosis per se. So I'll be discussing the topic under this heading: in introduction, the epidemiology, the risk factors, the pathogenesis, the disease spectrum, diagnosis and treatment. So what is this aspergillosis exactly? Basically, it is a ubiquitous group of molds which is found worldwide. That is, it is ubiquitous. It can be found in the soil, hay, compost, anything and everything basically. And they grow in the vegetative state, which is composed of long filamentous structures which are called the hyphae, and they are attached to the substrate and have as a serial hyphae which has a distinct appearance that resembles a aspergillum. So you can see in that picture there is something, this is an instrument which is used to sprinkle holy water. It resembles the shape of that. So that is why it got the name aspergillum or aspergillus. And this is associated with spores which are also called as conidia. So when you look at the various species of Aspergillus fumigatus is known to be the most common worldwide as well as in India. Other species which we are very familiar with we include Aspergillus flavus, niger, tereus, versicolor, nidulans, etc. Again, there are more than 344 species with less than 10 considered to be clinically relevant. So what is the importance of knowing a species? Again, as we know, the antifungal susceptibility will vary. So versicolor and tereus are known to be notorious for being resistant to amphotericin B. Aspergillus niger is often a colonizer rather than an invasive fungus. Your Aspergillus istus and Calidotustus tend to be resistant to multiple antifungals, and Nidulans has a tendency to be resistant to your echinocandins. So let's talk about the disease spectrum. So again, aspergillosis can cause pulmonary aspergillosis as well as extrapulmonary aspergillosis. Pulmonary aspergillosis we are very familiar with. Again, there is 4 major syndromes or clinical syndromes which are associated with pulmonary aspergillosis. That is include allergic forms, Aspergillus bronchitis, which is a localized form of aspergillosis. Then we have the invasive aspergillosis, which is a very severe form which is associated with very high mortality, and your chronic and saprophytic forms of the aspergillosis. So in the extrapulmonary aspergillosis, we have the CNS aspergillosis, the endocarditis, cutaneous aspergillosis, disseminated aspergillosis, and other local forms which can involve your eye, ear, as well as the bone. So, how does a patient, also what is the pathogenesis, or which are these patients who will develop aspergillosis? So, basic pathology or the basic the mode of acquisition is by inhalation of the aspergillus spore. So once inhaled, there can be colonization. What is colonization? It is nothing but isolation of aspergillus from lower respiratory tract sample without any evidence of the disease. So this colonization in a normal host, usually when the patient is normal, having good immunity, there won't be any sequelae. But even in normal host, when there is prolonged exposure or to high density conidia, or especially in hot and humid climate, it can go into chronic invasive aspergillosis also. And suppose the patient is having some sort of cavitary lung disease, this can progress to form aspergilloma, like the patient may have previous history of TB which has caused some cavities. Now this aspergillus will colonize inside that and form this aspergilloma. So otherwise the patient may be having some chronic lung disease, or patients with mild immunosuppression, then they can develop into chronic necrotizing aspergillosis. In a immunocompromised host, it go into invasive aspergillosis, and if the patient is having previous history of asthma, it can result in formation or result in a clinical condition known as allergic bronchopulmonary aspergillosis. So again, it is the basic pathogenesis or the pathology lies not in the fungi, it is in the host. So depending upon the type, depending upon the immune status of the patient, the various manifestation of aspergillosis is decided. So when the patient has normal immunity, usually it is just a fungal colonization. But again, as I have mentioned, if it is a very chronic exposure with a high number of spores, it can even lead to chronic invasive aspergillosis or a milder form called as Aspergillus bronchiectasis. So if the patient is immunodeficient, so it is more of invasive disease, which could be acute invasive or subacute invasive. If the patient is having hyperimmunity, so hypersensitivity syndromes like your ABPA, that is as allergic bronchopulmonary aspergillosis, allergic sinusitis, etc. So, acute pulmonary aspergillosis, invasive pulmonary aspergillosis with angioinvasion is more often seen in neutropenic, which occurs within days to weeks. Invasive pulmonary aspergillosis without angioinvasion, that is a form of bronchopulmonary aspergillosis which can progress between weeks to months, more often seen in case of patients who are non-neutropenic. So there are typical risk factors which are associated with aspergillosis. The classical ones include your neutropenic. So invasive aspergillosis, the major risk factor is your typical or classical risk factors are the neutropenic host. So this can be due to any acquired neutrophil defect, neoplastic disease, or the patients who are on high dose of corticosteroids, immunosuppressants, or any solid organ or bone marrow transplant recipients, and hematological malignancies, your HIV/AIDS, your primary defect of the neutrophils, and chronic granulomatous disease, that is where patients who are having recurrent bacterial and fungal infection in first year of life, usually they will present with multiple lymphadenitis or abscesses or hyper IgE syndrome or Job syndrome, which is nothing but a triad of skin abscesses, pneumonia, and increased IgE. So they will have candidiasis, arthritis, and ulceration, and typically these patients will present in the childhood and with the history of failure to shed primary teeth. So these are the typical risk factors which are associated with invasive aspergillosis. But nowadays there is increased occurrence of aspergillosis in non-neutropenic hosts. In that, the newer emerging risk factors include your COPD, chronic or acute liver disease, intracranial surgeries, reactive airway disease, or IV drug abusers, diabetes, or previous history of ABPA or asthma. So these are the various risk factors which can be seen in patients who are where you should be suspecting invasive aspergillosis. So coming to the clinical features. So again, the clinical features will depend upon the type of aspergillosis you are dealing with. So if the patient is just having how does a patient with pulmonary aspergilloma present? So basically when you ask the history, there will be typical history which is suggestive of some lung cavity like TB or anything or any lung abscesses, etc. So, and the patient will usually be present with hemoptysis, and that will be gross hemoptysis. So, and the imaging, the typical hyperdense mass filling will be there. Next, chronic pulmonary aspergillosis, as the name suggests, is a chronic condition where the symptoms will be presenting for more than 3 months. So again, chronic pulmonary aspergillosis can be of three main types, that is cavitatory, chronic pulmonary aspergillosis, chronic fibrosing pulmonary aspergillosis, and subacute invasive aspergillosis. Again, the patient, the symptoms may be similar, so but it is a chronic condition. So the patient may have just cough with sputum production or some history of hemoptysis, and over few months, and there will be usually typical background history of any pneumothorax, sarcoidosis, previous treated TB patient, COPD, etc. Typical immunocompromised status also could be there, and other emerging risk factors like diabetes, or patients on chronic alcoholic, etc. So again, the typical presentation will be the cavitatory, as the name suggests. So you will see that multiple cavities, consolidation, and aspergilloma can be there. In fibrosing, there will be extensive fibrosis, and subacute invasive. So this is a like precursor to your invasive pulmonary aspergillosis. So you will be seeing early changes of consolidation, cavitation, infiltrates, and nodules. The more severe form is your invasive aspergillosis. It is usually seen in patients who are, as I mentioned, the various risk factors of invasive aspergillosis, immunosuppressed, or the patients with neutropenia. They will be usually having these invasive aspergillosis, and usually they will present with, this is a rapid onset, that is acutely, the patient will be acutely ill with lung infection and hemoptysis, and the typical features include your halo sign, air crescent sign, etc. Hypersensitivity manifestation, again as I mentioned before, allergic manifestations of aspergillosis include your allergic bronchopulmonary aspergillosis, allergic aspergillus hypersensitivity pneumonitis, and allergic sinusitis. Usually they will have the typical history of asthma in them, and and the patient may have come with complaints of fever, hemoptysis, and typical central bronchiectasis is when you'll suspect the patient to have ABPA. So today I'll be discussing about invasive aspergillosis, hence I will not be going into detail of others. So in the subsequent session I'll be covering the various other forms, including your chronic pulmonary aspergillosis, allergic bronchopulmonary aspergillosis, etc. So now coming to the diagnosis, as I mentioned, let's talk about the diagnosis of invasive aspergillosis. So this I have taken from the practice guidelines for diagnosis of management of aspergillosis 2016 and 2017 ECMED ECMM ERS guidelines, as well as the diagnosis of invasive aspergillosis is based on the EORTC MSGERC guidelines, that is nothing but EOR, that is European Organization for Research and Treatment of Cancer and Mycosis, Study Group Education and Research Consortium. So for the diagnosis of invasive aspergillosis, so you should know who are the patients you are going to look for invasive aspergillosis. The various risk factors I mentioned, so any patient with organ transplant, neutropenic, on patients on immunosuppressants, and patients admitted in critical care with fever of unknown origin, having clinical symptoms of lower respiratory tract infection, and who remain febrile despite giving broad spectrum antibacterial, you will always have to suspect invasive aspergillosis. And what has to be done first? For that imaging modality of choice is CT scan, and in those patients who are having compromised renal status and you can't do CT, you can do the MRI in those patients. So for a diagnosis of any invasive aspergillosis requires three basic things. First is the host factor, second is the mycological evidence, and third, the second is the clinical evidence, and third is the mycological evidence. So coming to the host factors, basically EORTC has been updated. First, the 2008 guidelines has been updated in 2020. So let's look at the difference between them. So the typical host factors remain the same mostly. So again, the host factors more than 10 days of neutropenia, allogenic solid lung transplant patient, allogenic stem cell transplant patient, hematological malignancy, solid organ transplant, acute GVHD grade 3 or 4. So these has been added currently. Then patients who are on more than 3 weeks of corticosteroids, and patients on immunosuppressants which include T cell or B cell immunosuppressants, and inherited severe immunodeficiencies like CGD, SCID, and STAT3 mutations, etc. So basically these are the various risk factors you should be looking at in a patient you are suspecting. So then clinical features, clinical findings, like so at least one of the one CT scan sign, that is which first and foremost it can include your dense well circumscribed lesions with or without halo sign, a crescent sign, cavity, and this time they have in 2020 they have added wedge shaped and segmental or lobar consolidation. So patient, suppose a patient who is having who is a solid organ transplant, liver transplant recipient, and now the patient presented with persistent or he's febrile, and he is having some fever with cough. So in that case you'll always have to suspect invasive aspergillosis, and if the CT scan is showing your typical cavity or a crescent sign, then you'll have to look for the further evidence of invasive aspergillosis. Again, the pulmonary involvement of aspergillosis can be angioinvasive aspergillosis, where you will be seeing these typical signs that includes your micronodules, which can be surrounded with a halo of GGOs, that is ground glass attenuation, that is nothing but halo sign. There is one more form called the bronchoinvasive form, which may appear as tracheal or bronchial wall thickening, where you will be seeing the centrilobular nodules with tree bud appearance and patchy distribution, and predominant peribronchial areas of consolidation or bronchopneumonia. So basically, bronchoinvasive forms appears to be the early form of your invasive aspergillosis, which then progresses into your angioinvasive aspergillosis. So this will be the earlier CT features. So whenever you are seeing any central lobular nodules in tree and bud appearance with patchy distribution, in a patient having that risk factor, you should also again screen for your invasive aspergillosis. So other forms of invasive aspergillosis include your sinonasal disease, CNS infections, or tracheobronchitis. Then we have the mycological criteria. Here the major difference, first and foremost, you can notice is the cutoff for galactomannan antigen. So for mycological criteria, main important, apart from the direct microscopy or culture which is showing your aspergillosis, second most important is your galactomannan testing, galactomannan antigen in at least one, and the cutoff has been changed from 0.5 to 1. So a single serum or plasma galactomannan of more than 1, BAL galactomannan more than 1, or CSF galactomannan of more than 1, or if at all you are doing a paired sample, serum which has more than 0.7 and BAL more than 0.8. So basically these are the galactomannan cutoffs, and these are the values if the patient is not on any anti-mold prophylaxis. And other thing they have added is your aspergillus PCR as well. So more than 2 consecutive plasma or plasma sample which is positive for aspergillus, more than 2 duplicate BAL which is positive, PCR positive, or if only one is positive, so plasma and serum, serum and BAL fluid which is both positive for aspergillus, positive by aspergillus PCR. And one more important thing you will notice is this beta D glucan has been removed. So why are these changes? Why galactomannan? And why they have included aspergillus PCR, and why they have removed this beta D glucan, we will be discussing further. So how will you classify? So once these 3 criteria are met, so if there is only host and clinical criteria which is met, then you will be diagnosing the case as possible invasive aspergillosis. So host, that is the risk factors, and clinical criteria meeting, you will be diagnosing as a possible invasive aspergillosis. These cases you may or you may not treat based on the patient's condition, or you can just follow up the patient. So next, if the patient meets all the criteria, host, clinical and the microbiological criteria, you will be diagnosing it as probable invasive aspergillosis, and proven invasive aspergillosis you will tell only based on the histopathological diagnosis, that is recovery of hyaline or pigmented mold, which is seen, that is you will be seeing the typical histopathological picture of angioinvasive aspergillosis, that is the proven diagnosis. Apart from that, recovery of hyaline or pigmented mold, hyaline mold by culture or specimen obtained by a sterile procedure from a normally sterile site and clinically or radiologically abnormal site consistent with infectious disease process, excluding BAL fluid, a paranasal or a mastoid sinus cavity specimen and urine. So in that situation you can diagnose it as a proven invasive aspergillosis. So this is the very good summary chart. So when you are looking at the patient, so once the fungal burden is increasing, there will be more of dissemination. Initially the patient will have bronchiectasis. When the fungal load is less, there will be tree in bud appearance, then GGOs, nodule with a halo, then consolidation and dissemination. And if you can see the various markers, so again the serum galactomannan, BAL galactomannan has a better, is much higher, better sensitivity and specificity, especially specificity compared to your serum galactomannan. So now coming to the laboratory diagnosis. So the specimen which it can be sputum, BAL sample, tracheal aspirate, lung biopsy, or it could be even pus or tissue sample, or depending upon that involvement, it can involve even pleural, synovial cavity, peritoneal fluid, nail and skin sample. The diagnosis of aspergillosis can be done by direct microscopy or the fungal culture. But again, the fungal culture, the sensitivity of fungal culture is quite less, up to 40 to 50% only. So how to improve the sensitivity of these cultures? So first and foremost, it is recommended the sputum or the bile sample be liquefied using a mucolytic agent, and you have to do high volume culture, that is the entire sample should be inoculated to significantly increase the recovery. And to achieve optimal recovery of aspergillosis aspergillus from bile, you have to do the centrifugation, and then the sediment has to be processed further for the KOH and the culture to improve the sensitivity of the culture. Next, coming to the histopathology, as I mentioned, this is the only proven, this is one of the proven method for confirmation, or the proven criteria of diagnosis of invasive aspergillosis. So it can be subjected to H&E stain, PAS stain, or Grocott stain. So here you can see H&E stain showing the typical fungal hyphae. And microbial identification of the fungi. Why do you need to identify? As I have mentioned, depending upon the species, the various susceptibility pattern will vary. So hence it is recommended that you identify, and the identification of fungi by microscopy is also one of your mycological criteria. So it can be by a KOH, calcopho-white mark, or the gram stain. And as we know, the identification of the species is based on the morphological features. I will not be going into detail of this. Then important test is your serology. Basically, as I mentioned, the sensitivity of your cultures is very low. Hence, galactomannan test is one of the rapid tests which is easily available, and it has a better sensitivity and specificity. So this is a polysaccharide that is a major constituent of Aspergillus cell wall, and it is soluble, heat stable antigen, and which is released only during active cell replication, that is during the hyphal growth. So because it is released during that, only during active cell, so it can easily differentiate your fungal colonization from your invasiveness. So it is a very specific marker for your invasive aspergillosis. And detection, you can detect galactomannan in fluids like bile, CSF, which is more sensitive than your serum. And how do they report this galactomannan in terms of optical density index? And we have various formats which are approved by WHO, include your Platelia, Aspergillus that is enzyme immunoassay, and IMI lateral flow assay. So why are we doing galactomannan? So this galactomannan can be positive as 5 to 8 days earlier than appearance of the clinical symptoms of invasive aspergillosis, and 7 days earlier than the appearance of HRCT, and that's why it leads to an early initiation of empirical antifungal therapy by median of 12.5 days. So it's a very good and useful marker for invasive aspergillosis. Again, the sensitivity varies from 30 to 100%. Specificity is most of the situation is more than 75. So this is a summary of various studies where again the sensitivity is better in patients who are having neutropenia than in patients who are non-neutropenic, but the specificity is always very high. So you can see in adult neutropenic the sensitivity is 30 to 100%, but in case of non-neutropenic the sensitivity is around 37.8%. In pediatric again 80 to 90%, 80 to 100% sensitivity, whereas the specificity is very good. Again, there are various studies which have demonstrated various results. Again, these are the studies which are on serum, but if you see the bile sample, the BAL sample has much better sensitivity and specificity. So, if you are highly suspecting invasive aspergillosis and a serum galactomannan is negative, you can, if the patient condition allows you to do, so BAL sample is recommended over the serum sample. So, BAL sample you can see in in the neutropenic 57% specificity is around 95%. In non-neutropenic again 75% sensitivity and 80% specificity. So coming to your just a brief about the various platforms which we have for galactomannan testing. One is Platelia Aspergillus antigen kit. So it detects in serum, BAL, CSF and urine with a detection limit of 0.5 ng with a turnaround time of 3 hours. It's a direct sandwich ELISA which uses rat monoclonal antibody. And how do they report is based on the OD index, that is, and the sensitivity for serum when the OD index is more than 1 is 65 to 71%, specificity is 90 to 94%, and for BAL when we use ODI of more than 1 the sensitivity is 75 to 86%. Lateral flow assay by IMI, that is one of the more point of care test which is available. So again it has been approved for serum and BAL samples and it is based on lateral flow. It requires a special instrument known as cube reader for calculating the GM galactomannan OD index, and limit of detection is 1 nanogram per ml and you can get the results as early as 45 minutes. Again it has a sensitivity of around 70 to 77%, specificity of 96 to 81%. Then lateral flow device Aspergillus LFD. Again it can be qualitative and quantitative. It's a simple rapid digital readout and based on the lateral flow assay. It has a TAT of 15 minutes and again the sensitivity and specificity is on the similar range. And one issue with galactomannan is the false positivity. So before it has been known that it has the galactomannan is associated false positivity with the patients who are on piptaz, amoxicillin, but the recent formulations of piptaz and piptaz is known to be there is not known to be cross reactivity with galactomannan, but there can be some cross reaction with plasmalide, cotton, cardboard, soybean protein. And one other important thing is galactomannan is not only positive found only in the Aspergillus cell wall, but it can be found in others, which it could be a penicillium species, histoplasma, and others fungi like Alternaria, Cladosporium, Bifidobacterium, etc. Next, let's talk about why beta-D glucan has been removed. Glucan is a pan-fungal marker which is a major constituent of most of the fungal cell walls. So what are the exceptions you need to remember? It is negative in cases of your Cryptococcus as well as Zygomycetes, and it has a limited role in invasive aspergillosis. Why? Though it has a good sensitivity and negative predictive value, it is not specific just for aspergillosis, and hence it is not used in, and that's why it has been removed from the EORTC for diagnosing invasive aspergillosis. But in case you want to use, you can use it as a adjuvant, like you can do 1,3 beta glucan as well, then along with your galactomannan. This will further increase the sensitivity and specificity of your galactomannan. So comparing these two markers, so beta-D glucan routinely it has been used for Candida as well as aspergillosis, mainly for Candida, whereas galactomannan mainly for aspergillosis. Other positives are very important to be noted. Beta-D glucan will be positive in cases of multiple fungi like your Pneumocystis, Histoplasma, Fusarium, dermatophytes, Coccidioides, etc. So important exceptions which you need to remember for beta-D glucan, as I mentioned, Cryptococcus, Mucorales and Blastomyces dermatitis. And one important thing, so your Mucorales are beta-D glucan as well as galactomannan negative. Galactomannan can be false positive along with whatever I mentioned like Fusarium, Penicillium, Histoplasma, Blastomyces, Cryptococcus, etc. The major issue is the false positivities, especially in cases of patients with, when you're considering beta-D-glucan, your IVIG, albumin, and other blood products, and IV penicillin formulations, hemodialysis with cellulose membrane, cellulose filters for IV, gauze packing. So all these are associated with false positive beta-D-glucan. So next, let's discuss about the molecular diagnosis or PCR, Aspergillus PCR in cases of invasive aspergillosis. Again, in patient group which are undergoing allogenic stem cell transplant and in patients with hematological malignancy, PCR alone is not associated with good sensitivity. Again, it is equivalent to that of your cultures, around 40 to 50% sensitivity. By adding PCR and galactomannan, it can increase the sensitivity and specificity. And in case of CNS aspergillosis, the sensitivity was 100% and specificity was 93% in one of the studies which was done on hematological malignancy. And molecular diagnosing on biopsies, whenever in biopsy samples, if there is visible hyphae, then it had a higher sensitivity. Without any visible hyphae, the sensitivity and sensitivity was low. Specificity again, molecular test, it has a good specificity. So summarizing the various markers in diagnosis of invasive aspergillosis, so which of it can be used in early detection? Almost like galactomannan, PCR, lateral flow device and beta-D-glucan can assist in early diagnosis. Whereas beta-D-glucan has a wide broad range pathogen detection. PCR again can detect broad range plus or minus. Galactomannan is relatively specific for your invasive aspergillosis, and identification of species to the species level is possible only with the PCR and not by any other biomarker. And all of these are associated with good performance, and galactomannan and beta-D-glucan, you will have the quantitative results as well, and rapidly available. So when you look at the rapid availability of galactomannan and beta-D-glucan, PCR is not, as we know, it is not possible in all the places, and lateral flow device is the most rapid, which will give results within 15 minutes. But again, the availability in India is a question there. And galactomannan, the cost can vary between 3.5 to 5,000. Beta-D-glucan is more expensive, and because it has lower sensitivity for your or specificity for aspergillosis, so we don't do routinely beta-D-glucan. So how can you use biomarkers to assess the patient's response? It is necessary that you do serial monitoring of the serum galactomannan. So once it is elevated, once a patient is sufficiently treated, the galactomannan levels will fall down. And you can use galactomannan, not beta-D-glucan, for monitoring. So coming to the management, so in order to understand the treatment, you need to know the various intrinsic resistance with the antifungals. So in Aspergillus species, your Aspergillus fumigator is inherent resistant to fluconazole. Tereus, flavus and nidulans are resistant to your amphotericin B. Again, this is a various susceptibility again among your other common species. Aspergillus fumigator is known to be resistant to your itraconazole and voriconazole and posaconazole. It is rare, but it is increasing. And the Tereus, as I have shown, amphotericin B intrinsic resistance is there. So important points to remember in treatment of invasive aspergillosis is first of all, the various only patients who are probable or proven need to be treated. So possible, again, for providing the definite diagnosis is quite challenging. And these diagnosis criteria which I have mentioned is designed for basically clinical studies to look at the various biomarkers and then do this for study purpose or epidemiological purpose. So for clinical decision making, you shouldn't be waiting for confirmation. So whenever there is a possibility of invasive aspergillosis, you need to be treating the patient without any delay. So any patient at the risk of invasive aspergillosis should receive antifungal treatment, and how long you need to treat depends upon the clinical response and immune reconstitution of the patient. And triazoles are the preferred agents in that, especially the drug of choice if they ask it for invasive aspergillosis is only voriconazole and not fluconazole or any other. So alternatively, you can use liposomal amphotericin B isavuconazole, and amphotericin B, as we know, and is used, that is basically the liposomal derivative is used for salvage therapy when voriconazole can't be administered. Echinocandins again are effective only as a salvage therapy, either as alone or combination therapy, and should not be used as a monotherapy in primary treatment of invasive aspergillosis. And when you look at the duration of treatment, you should be giving minimum of 6 to 12 weeks. And again, it is not compulsory that at the end of 12 weeks you need to stop, but the duration is largely dependent upon the degree and duration of immunosuppression, the site of the disease, and evidence of disease improvement. So as I have mentioned, the primary therapy remains voriconazole. So initially you will give it the dose of 6 mg per kg for first day, followed by 4 mg per kg BD dose. So initially mostly it will come up to like 400 mg BD for on the day 1, followed by 200 mg BD. And again, the dosing should be actually voriconazole based on the therapeutic drug monitoring and achievement of the therapeutic target. So alternatively, liposomal amphotericin B 3 to 5 mg per kg per day can be used. Isavuconazole is again the one of the newer antifungal which is known to be as effective as voriconazole with but again the major limitation is the current cost of the antifungal. Posaconazole also has been studied. There are various studies which have proven that posaconazole is as good as voriconazole. So again that can be used in the treatment as a part of salvage therapy according to the current IDSA guidelines. And primary combination therapy is not routinely recommended. So addition of any other agent or switching to another drug class can be used in patients who require salvage therapy. And dosage of pediatric patients for voriconazole and caspo is different, and posaconazole has not been defined, dose has not been defined in pediatric patient. And minimum duration, as I mentioned, it is 6 to 12 weeks. And if required, subsequent immunosuppression secondary prophylaxis can be added if there is chances of recurrence. So these are the drug doses. The important side effects you need to remember: voriconazole can cause hepatotoxicity. So again you need to monitor that. Skin sensitivity and visual disturbances. So you can ask the patient if he is having any visual disturbances. And voriconazole associated joint lesion osteomyelitis is also common. Then posaconazole, important thing is initial dose is 200 mg PO QID will be given, followed by 400 mg BD per oral. So this important instruction you have to give with for posaconazole, they have to take it with a fat meal which increases the absorption. So what are the adjunctive treatment for invasive aspergillosis? That is, so most of the patient, as I mentioned, the patients will be on any immunosuppressants because either they would have received the any grafts or transplant. So reducing the dose or eliminating or stopping the immunosuppressive agent if whenever feasible. Recombinant interferon gamma is recommended in patients who are as a prophylaxis in CGD. And surgery for local disease can always be tried, and patients who are known to have prolonged neutropenia can try GM-CSF as well. So again, this is a very important slide. So disease, the treatment of with an antifungal. So it can be given as a prophylaxis when there is no evidence of the disease, empirically when there is some symptoms of the disease, preemptive when there is some symptoms as well as there is some marker which is positive, that is asymptomatic with colonization or positive novel diagnostic test. Targeted therapy when there is symptoms and their patient is having some disease and some confirmatory evidence is available. So for the prophylaxis for invasive aspergillosis, where you will give this, again the patients who are on immunosuppressants and who are the transplant recipients. So prophylaxis, posaconazole is preferred over voriconazole in patients who are at high risk for invasive aspergillosis. In case of lung transplant patient, voriconazole or itraconazole should be given for at least 3 to 4 months after lung transplant. And for those patients with who have been successfully treated for IPA and who require immunosuppression, secondary prophylaxis should be initiated to prevent the recurrence. So when should patient be treated empirically with an antifungal? So it is recommended in patients who are at high risk for prolonged neutropenia and who remain persistently febrile despite broad spectrum antibiotic. So in that situation, antifungal option include amphotericin B, echinocandin or voriconazole. So you can use the seromarkers like beta-D-glucan and the galactomannan for preemptive therapy. And one last important topic is the therapeutic drug monitoring. This is a very important part which is not usually done. So it is very necessary that you monitor the level because the therapeutic window of both voriconazole and posaconazole is minimal. So that is why there is recommendation for therapeutic drug monitoring and maintaining the voriconazole prophylactic range between 1.5 to 2 and therapeutic between 1.5 to 2. And when you should do the sampling after 2 to 5 days after the therapy. So then there is this equal aspergillosis score. So basically this equal scoring is not for diagnostic criteria. Basically this reflects how much you are following or adhering to the current guidelines. And so this is a scoring system. So you can see it is looking at whether the patient is having risk factor and they are doing galactomannan screening, or the patient is on anti-mold prophylaxis, and after whether they have done CT scan, etc., and whether BAL galactomannan. So there is different scoring which is given, and first line therapy. So they will add the score. So if higher the score, higher the compliance to the current guidelines. It is not of any diagnostic importance currently. So this is an algorithm which can be used. So any patient who is having persistent fever, you should having persistent fever and having risk factor for invasive aspergillosis and having clinical features of fever, cough, etc. So you will have to look for the risk factors, that is high risk factors like neutropenia, hematological malignancy, transplant, etc., or any other intermediate risk factors like prolonged steroid, COPD, and the various newer emerging risk factors which includes prolonged ICU stay, malnutrition, diabetes, etc. You will look at assess whether the patient may be already on broad spectrum antibiotic. You will look at whether that antibiotic dosage appropriateness is there, of therapy is present, and whether if the patient is having any catheter or any central line, assess for the requirement of the presence of that. Then you will have to do chest x-ray and CT scan thorax or head depending upon the site of involvement. Then the other investigations, the common inflammatory markers, procalcitonin, CRP, CBC, and serology, galactomannan is very important. Beta-D-glucan if you can be done. PCR if it is available, and again with the serum sample, if it can be done, you can do the BAL or ET aspirate or the CSF. And various cultures again to send it is very important. Blood culture, fungal blood culture for both aerobic as well as fungal culture should be done. Then the patients who are at high risk and having typical signs on CT with galactomannan positivity, that is which meets the EORTC criteria of galactomannan more than 1. So the patient will be classified again as possible, proven or probable. we will be starting the antifungal. Patients who are at intermediate risk, that is those patients who are having no neutropenia, if the CT is suggestive of invasive aspergillosis, or the aspergillosis has grown in culture, or galactomannan is positive, again you could be starting the antifungal. Who are at low risk, you can monitor. If there is some CT changes with galactomannan positive, you will be starting the antifungal. If there is no, the culture is negative, or if the CT there is no significant or the typical changes, or galactomannan is negative, there you will not be starting any antifungal, and you will be choosing to monitor the such patient. So getting back to the case, so we had the 30-year male who was a carpenter who presented with altered sensorium and with seizures, and we had evaluated for meningitis. We were suspecting query fungal meningitis, TB meningitis. So his CSF we had sent for various cryptococcal antigen, etc. It was negative, whereas CSF galactomannan was 2.46. He was started on voriconazole, and day 2 of treatment he had a great or the excellent response to the therapy. Hence, it is very necessary that you always think fungus whenever the patient is having the various risk factors as I have mentioned. So what were the risk factors for invasive aspergillosis in this patient? So previous TB, so there could be some cavity, and diabetes which was uncontrolled, which is a newer emerging risk factor, drug abuser, and multiple hospitalization with broad spectrum antibiotics as well. So these were my references, and thank you. So today's World Aspergillosis Day, Feb 21st, think fungus. So with that, I conclude my session. If you liked my session, don't forget to like, share and subscribe to my channel. Thank you.